Hello everyone, thank you for being here. This is really exciting. So it's 10 o'clock at night. I do have my glass of scotch, makes the vocal cords go nicely. And tonight I've got 5 cases and some questions to work through. It's fairly unstructured, it's going to be informal. We'll take some time to have a look at some of the questions you guys have submitted beforehand, as well as the ones that you're writing in today. But before we start, I just wanted to say how amazing the response to this conference has been by everyone. The number of people that have subscribed and the number of people who are watching the lectures and the feedback we're getting. And it couldn't have been made possible without all the hard work of people like Dixon, who the last thing he needs is to have even more ego. But the reality is that this is his love child. And all the amazing speakers that have agreed to give these fantastic talks. So thank you. Thank you all for being here. I know the last 6 months have been tough for everyone. And it's wonderful to see that we can have a little place here, a small community, where we learn from each other and get better. So without further ado, let's start off with case 1, and hopefully some of you have had a chance to have a look at these cases before we've started, and if not, that's okay. We'll be scrolling through them together. The cases sort of starts with easy cases or easier cases. The later cases are more complicated, but with each one I think there are lessons to be learned at various levels, so hopefully you'll all get something out of it. So this case 1 is of a 30-year-old man with pain down the back of his leg and into the bottom of the foot. And we're going to get ourselves an MR. And so here we go. And immediately we can see a disc protrusion here. And we can see the rest of the disc spaces are really normal. When you see a beautiful midline cleft like this, nice hydration of the disc, you're almost certainly not going to find significant disc pathology. This is the only abnormal disc. We can see it's lost some of its T2 signal. And we've got a disc protrusion posteriorly elevating posterior longitudinal ligament and theca. And if we go into axial, we can see it here, compressing this descending nerve root in the subarticular recess. Great. Done. Let's number it. That would be 5, 4, 3, 2, 1. And so the nerve root coming out from there, if that's 5 and that's 4, that's going to be L4 or L5. And we're done and we can move on. And the problem here is that the history was of pain going down to the bottom of the foot and the back of the leg, which is S1 distribution. And we've identified, if this is 4 and 5, then we've identified the descending nerve root in the subarticular recess, which would be the L5 nerve root. And so this doesn't match clinically. So we're going to talk a little bit about how to number transitional anatomy. And this was one of the questions that was sent in. And for transitional lumbosacral anatomy, we usually routinely count from C2 and label them. Well, that's if you're lucky enough to have scouts that go all the way from the top. But what do you use if you don't have that? And actually, part of the question is, even if you have them, should you always count from C2? So let's first talk about the simple things that you'll always have just on the lumbar spine MR, no matter how targeted the study is. The first thing is that the L5S1 disc is wedge-shaped, whereas most of the other discs are more horizontal. So if we have a look at this disc, this already has a bit of a wedge in appearance compared to, say, this one or the one below it that are more horizontal. So that, at first glance, would make you think that this was the L5S1 disc. Well, let's look at the conus. Ends probably there. I always use axial to check where the tip of the conus is, because bunched up nerve roots can make it appear that the conus terminates further down than it actually does. And slight gaps between slices can make it appear that the conus terminates too high up if the tip falls between sagittal slices. But here it looks to be that level. Conus almost always falls somewhere between the superior end plate of L1 and mid L2. It's pretty uncommon for it to be above the inferior end plate of T12. So this would make this most likely L1, 2, 3, 4, 5. So that's 2 votes for that being L5/S1. While we're on sagittal, we can swing across and try and spot ribs. Now, ribs on MR are surprisingly difficult to look for. And also they're unreliable because it's not terribly infrequent to have a small stubby 13th rib, or perhaps an unfused transverse process of L1, or some patients have really terribly small 12th ribs, but it's yet another thing to put into the equation. And here we can see a rib, and on the other side we can see it too, just at the very top. So that would make this 12, and so 1, 2, 3, 4, 5. So now we've got 3 things pointing to this being L5/S1. Moving on to axial. So people do talk about the morphology of the L5 vertebral body, looking like Napoleon wearing a hat. Personally, I find that when it's lumbarized, S1 kind of looks like Napoleon wearing a hat as well. Plus, you have to be familiar with what Napoleon looks like, and I guess that looks more like Paddington Bear. But in any case, I don't put too much weight on the morphology. What is very useful is the iliolumbar ligaments, and here you can see them on either side, extending from the ilium to the transverse processes of L5. There it is there. Nice black band heading across, and we can see it on the other side also beautifully. These are meant to be extremely reliable. The paper that springs to mind quoted 98% reliability. I don't remember any of the details. I don't remember how they decided what the true L5 vertebral body was. I don't remember how many transitional cases there were. But as a sort of sense, it is highly accurate. And in practice, I find it to be really very useful as well. The last one, which I think is actually more useful than pretty much all the ones that we've talked about at this particular level, because it gets to the heart of the matter, which is you're not so much interested in which nerve you're going to call, you're interested in which functional nerve is affected, especially in a patient who has multi-level degenerative change and you're trying to identify which the symptomatic nerve is. And that is looking at the size discrepancy between the L4, L5 and S1 nerves as they lie on the sacral ala. So if we come down and there, that's probably the best look. This is a pretty easy to identify landmark, sacral ala, and then you'll have nerve roots sitting in front of it. The L5 and the S1 nerve roots are about the same size, whereas the L4 nerve root is much, much smaller. So if this was the L5, then we'd expect the L4, often 2 little nerve bundles, much smaller than the L5. Whereas when you see 2 nerve roots or 2 nerves side by side that are roughly the same size, that strongly indicates that that's L5 and that's S1. And then you can follow them up. Check, and there it is there. So down, so S1, L5. So in this instance, we have at least 4 things just in the lumbar spine pointing to the fact that this is a lumbarized S1 and that therefore L5 is coming through this subarticular recess and being impinged upon right there. Of course, you can count from the top, and that's great if you've got that, and increasingly we're getting this routinely on all our scans, so you can number it. And the benefit of this, more than anything, is to make it easy to explain how you've decided to lumbar it. The really key point to lumbering transitional anatomy is not so much getting it right, but being transparent with what it is that you're saying. And that's particularly the case if there's prior imaging that might have labeled it differently, or there's prior imaging and you don't know how it's been labeled. And there the key is to be precise and transparent so that everyone can understand how you've come to the conclusion that you have. Sometimes pragmatically it's easier to just go with prior numbering, and sometimes you have to say, actually they got it wrong. And this is the correct numbering. This is why I'm calling it this. This is what they've called it before. And in this case, you would want to correct it because it's the symptomatic nerve root that's being compressed. So let's have a quick look at some of these questions and see if they're there. Oh, thank you very much. Hello, everyone. L5. So S1. Is it the L5 being impinged in lateral recess? So at L4-5 disc space, the nerve root that's going through that subarticular recess, so exiting the level below, will be the S1 nerve root, correct? And yes, you can use conventional radiographs or CT to count vertebrae. Plain films are hard because once you get into the thoracic region, you lose much of the detail. And remember, in theatre, if they're using intraoperative screening, it's almost impossible to count all the way from the base of skull through the shoulders in a operative patient. So let's move on to case 2. And here we've got a 40-year-old female with blurry vision. Not a terribly subtle abnormality, even on the non-contrast T1. And when you give contrast, you can see it vividly enhancing. It seems to displace gyrus rectus out of the way, pushing the anterior, communicating an anterior cerebral artery out of the way. And if we go to coronal, you can see a nice little dural tail, which is not pathognomonic from an angioma, but highly suggestive in this setting particularly. So there we go. And if we look posteriorly at the chiasm, we can see that the chiasm is a little bit elevated at this level. And as we come forward, immediately the left-sided nerve root, prechiasmatic optic nerve, becomes high on T2. And so there we go. Cause of blurring of the vision, a planum sphenoidale or tuberculum sella meningioma. Move on, next case, easy. The problem with this case is that yes, the stretching of the chiasm is a big concern in this patient. But the real finding that you have to look for, and have to tell the surgeons about is that. And that's a small tongue of tumor that's grown into the optic canal and is compressing the optic nerve. When we come further forward, we can see the optic nerves behind the globe are really very asymmetric. On this side, we have it's hard to know what size that optic nerve is. It looks small, but it's difficult to judge because the degree of CSF surrounding the optic nerve in the optic nerve sheath is much, much less. And whenever you have great differences in T2 signal surrounding a structure, it becomes really hard to identify the size of the structure or the internal signal. So you could zoom this up, maybe take a ROI to try and understand whether there is high T2 signal within the nerve. There probably is because we see prechiasmatic high T2 signal. The fact that there's no CSF here tells you that there's obstruction to the normal communication between the subarachnoid space and the optic nerve sheath. And it's due to this tiny little amount of tumor in there. Now, in this patient, the surgeons will probably see that, but they'll have to see it on the scan because intraoperatively, this is not an easy region to get to. If they come from a lateral approach, then they'll be looking at the meningioma this way and they're not going to de-roof the optic canal. to try and get to this, which is on the other side of the optic nerve, which is stretched over the top. And if, as increasingly is the case, you might have a transnasal endoscopic approach that way, well, you're certainly not going to be deliberately opening up into the optic nerve canal. So it's really important as radiologists to identify on all your scans that have meningiomas in this region whether there is tumor extending down into the optic canal. And to do this well, you need fat-saturated sequences, but you need more than just fat-saturated. You really should be getting spin echo or black blood sequences. And by black blood, try saying that after a glass of whiskey. By black blood, I mean sequences where flowing blood appears black. Increasingly, we're doing 3D volumetric scanning for post-contrast T1s, such as an MP RAGE, pre and post-contrast. And that's great because you get all three planes in one go and you can reconstruct it and there's no skips between adjacent slices. The problem is venous blood as well as arterial blood will all be bright white, and it can make small amounts of tumor much harder to identify. So fat-saturated spin echo or black blood sequences through the base of skull is really crucial if you want to identify these small amounts of tumor. Now, in this case, your attention was also immediately drawn to the large tumor, and so it was easy to find. But remember that you can develop a meningioma just in there. Just that one little 3mm meningioma all on its own is enough to cause optic nerve compression, optic atrophy, and eventual blindness. So it is a check area. Super important to look at it all the time, every scan, especially if there's any visual symptoms. Let's have a quick look at what people are writing. You're a huge fan, Janela. That's lovely. Thank you. Thank you for coming along. And more comments like that will just drive Andrew Dixon crazy, so keep them coming. So sphenoid meningioma, not quite. That's really planum sphenoidale, which is that flat blip. We don't have a sagittal image to show that this goes back and probably creeps into the pituitary fossa, making it a pituitary, a tuberculum sella meningioma. And am I on Twitter? Yes, I am on Twitter. Dr. Frank Gaillard on Twitter. Find me there. I'm not on Twitter very much. Social media is a bit of a drag lately, but I have been on for this conference. Okie doke. I can't believe I just said okie doke. And someone was saying whether it was still good to say groovy. I've dated myself terribly. Another pre-submitted question. Can you please make a comparison between conventional 2D flare and 3D? What are the pros and cons? What do you prefer? So what I prefer is entirely dependent on the clinical indication. More and more we're doing 3D flare, and more 3D flare look as nice as 2D flare. The advantages are kind of what you expect. You have a volume, so you're obtaining all three planes simultaneously, and you're able to reconstruct it into any plane you want. And it makes a comparison between different studies much easier. There are tools coming out. If you've seen my MS lecture or previous talks on MS, you'll see that one of my interests is computer-aided detection of new MS lesions, and having 3D volumes that allow you to co-register multiple studies together and reslice them precisely and even do advanced subtraction, etc., is a huge bonus. So if in doubt, do a 3D. The downside of it is primarily that it looks a bit different. And if you're used to, particularly in tumors, looking at conventional flare, it can take a while to get used to it. And so much so that at my institution, we're doing both in gliomas. We do a 3D flare and an axial conventional flare. And at some point, we're going to ditch it. But we still just like to see that conventional flare. It does make things easier. Case 3. 50-year-old male with increasing headaches. Now this one's a long one, so a glass of water instead of whiskey. So a very subtle lesion in this one, a great big lump, cystic component, solid component, edema. And if we go to, let's just jump straight to contrast to get it over and done with, we can see that the solid central component vividly contrast enhances. There's nodular components. Some of it is smooth. Some of it's lumpy. Inferiorly, we have another few septations. No other areas of contrast enhancement. If we move to this flare, we can see that there is surrounding edema. Now, Andrew's given a talk on cytotoxic versus vasogenic. In tumors, it's definitely not cytotoxic. But the word vasogenic is also has to be used with caution, because you can have vasogenic edema with tumor infiltration or non-enhancing tumor that is also T2 bright. The distinction between non-enhancing tumor and pure vasogenic edema is not easy, but it's mostly to do with T2 signal and ADC values or ADC appearance. Quick clue here, if you're in any exams and you ever see these on the skull, that means someone, at least on the basis of CT, thought that they were going to operate, because these are fiducials for stereotaxis. So let's have a look at this area of edema up here, because I think this is a nice example of just how bright vasogenic edema can get. Perfectly spares the cortex. It washes up against the cortex and stops. The cortex is normal in thickness. It's maybe a little bit stretched because the gyrus is expanded. And the signal intensity of this area is almost CSF-like. When you go to flare, it's so almost CSF-like that you start getting some flare suppression. It doesn't go black, but the signal drops. Note how this central area here is darker than the more peripheral areas. And when you check on T2, it corresponds to this super bright area here. And that's telling you there's so much additional extracellular fluid that there are literally pockets of fluid that are large enough for flare to attenuate. We see this phenomenon very prominently in a tumor that no longer exists according to the WHO, which is protoplasmic astrocytomas. And when you see that feature within the tumor, areas of tumor that are not cystic, but are very bright on T2 and then suppress on flare, it's a very good indication that you're looking at an astrocytoma and not an oligodendroglioma. And here it's just telling you that there is abundant vasogenic edema. One thing to note though is that this edema does not spread equally around this tumor in all directions. And that's the first warning bell that this is not perhaps a solitary metastasis, which is the main differential in this instance. Because vasogenic edema around a metastasis tends to spread in every direction as far as it does in every other direction, except where it runs into grey matter. And here anteriorly, we have much less vasogenic edema than posteriorly. Here anterolaterally, we have a great deal, but more medially, we don't have much. Maybe it's running into basal ganglia. Inferiorly, there's really not much below here. There's a lot running down into the insular cortex and operculum. But the real bit that's a worry is this component here. We see it better on flare, and this is the component that's heading across the corpus callosum. Edema tends not to go across the corpus callosum, and that's because corpus callosum is extremely tightly bound axons together that resists the normal spread of vasogenic edema. When you see this tail of non-enhancement, or especially if it's enhancing, tumor going down towards the subependymal region and across the corpus callosum, that's a very glioma thing to do, not a very metastasis thing to do. And if we switch our attention to ADC, so one thing, I don't like DWI very much. For those of you that have heard me speak before, I tend to bang on about this. I'm going to continue to do this because I think this is really important. The only reason to look at the diffusion weighted imaging, or the B1000, is to tell you where to look, because what you're trying to assess is the diffusion characteristics of this lesion. There are some exceptions, but generally you're just after what the diffusion values are. In this case, you know where to look based on the other sequences. So you don't need the DWI. You want to go straight to the ADC, and you want to get used to measuring these values. You can put a ROI on it. Normal white matter is about 750 times 10 to the minus 6 millimeters squared per second. This CSF, normal CSF, will be about 3,000 to 3,200. This looks about the same. And this edema, I mean, it's not like CSF, but it's getting up there. That'd be in the 2000s. Notice how anteriorly, where we didn't have as much edema, the values are lower. And particularly in this component, they're a bit lower. And look at this area here. This area does not look like this area. This tells you that it doesn't have as free a movement of water. And that is probably because there's lots more infiltrating cells through there. And that's particularly the case down here inferiorly. In the solid component and the enhancing components around the margin, we're seeing low values, at least as low as white matter, possibly lower. So by the time you get a tumor that has ADC values that are as low as normal white matter, you're looking at a highly cellular tumor. The only tumors that have lower values than normal white matter, you're looking at small round blue cell tumors like lymphoma, medulloblastoma, pineoblastoma, and you're looking at highly cellular glioblastomas or gliosarcomas, and of course pus, and of course infarct. And this is clearly not an infarct. This is clearly not pus because there's no diffusion restriction within the fluid component. And so you're left with a highly cellular tumor, and this doesn't look anything like a lymphoma or medulloblastoma or pineoblastoma. So you're really left with a glioblastoma. And this patient went on to have histology, and sure enough, that's what we've got. Now, we're not going to spend too long today speaking about IDH1 mutations, because by the time you're looking at a glioblastoma, the distinction between an IDH mutant glioblastoma, which incidentally, you won't be able to call that anymore. You'll have to call it a diffuse astrocytoma or a diffuse IDH mutant astrocytoma high grade, grade 4 in the upcoming WHO revision, or an IDH wild type glioblastoma. Both of those have terrible prognosis, wild type worse. But generally you often satisfy yourself with just immunohistochemistry. We'll talk about that a little bit when we get to a case later on. High topoisomerase, so rapidly dividing tumor glioblastoma. So let me just quickly check to see if there's some questions here. So my Twitter handle is just Frank Gaillard. Go figure. Should have known that. And hemorrhagic foci, no diffusion restriction, correct. So pilocytic astrocytoma is a good thought. He's 50, which is pushing it age-wise. Usually when you see pilocytic astrocytomas in adults, they are more unusual in appearance and could certainly look like this. They're often periventricular or around the base of the skull optic radiations. They tend to be more aggressive. But that's not a bad thought, along with other unusual gliomas such as a parenchymal ependymoma, for example, but you don't see very many of those. In terms of, is there any cutoff to differentiate between benign and malignant lesions on ADC? So there's a couple of points here. Firstly, the term malignant and benign when it comes to brain tumors is something I don't like. I think most people don't really use it, because when you think about the pathological features that distinguish a benign from a malignant tumor in the rest of the body, most of those are absent. So when you think of what makes a malignant tumor in the rest of the body, you're talking about direct invasion into adjacent organs or structures. Glioblastomas don't do that. They remain confined to the brain. Occasionally they'll CSF seed. Metastases, glioblastomas almost never do that, except again for CSF seeding, which is not terribly common. Whereas benign lesions, well, to call a tumor that will kill you in 3 or 4 years with some of these low-grade tumors benign seems like a poor choice of the word. So we talk about grade instead, so low grade, high grade. In terms of a cutoff, no, there's no cutoff, and I'm a great proponent of the use of ADC as an additional sequence and an additional data point to help you understand what's going on. And the pushback that I get most by critics of this is that the numbers aren't that good. And it's true. They're not magical single values that let you definitely differentiate things. But they are helpful in giving you a sense of the kind of histology that you're looking at. And when you combine that with morphology and demographics and other sequences, it's very, very helpful. As a general rule, having said all of that, as a general rule and with a great deal of overlap, let me see if I'll actually draw this. So if there's a lot of moving parts here, so if things break, excuse me. So if we look at ADC values in this axis, and we're going to look at grade 2, grade 3, and grade 4 diffuse gliomas, we're talking here. And we'll talk about, well, let's put normal over here. So normal white matter will be at about 750. Normal CSF will be 3,200, say. So if we're talking about a grade 2 tumor, grade 2 tumors are unable to get rid of CSF as well, get rid of interstitial fluid as normal brain is. So they accumulate more fluid, which is why they're bright on T2 and why they exert positive mass effect. The positive mass effect is not really because of the extra cells. I mean, there is a little bit, but it makes up a tiny fraction of the overall mass effect. And so because there's extra fluid, what we see is an increase in ADC values. And we'll put an arbitrary number of 1,000 here. And so grade 2 will tend to be around 1,200. But of course, you know, there's a big range in these values. Grade 3 will tend to come down to about 1,000, again, with a range. And grade 4 tumors will come down to about that of normal white matter. And that's why I was saying that by the time you get to the normal values of white matter, you're looking at a highly cellular tumor. If we look at lymphoma, say, then that's when you start getting below normal white matter. So 500, 600. Stroke, you know, will get very, very low. But that's a very different question because you're looking at normal brain that has undergone pathological change rather than normal brain infiltrated by additional cells that are affecting its normal fluid homeostasis. So hopefully that makes some sense. Okay, let's move on. So we've got a diagnosis here, and that was only the start of that case. So normal treatment for glioblastomas? Anyone? STUP protocol, STUPP, which, you know, it was fairly revolutionary. Before I did radiology, some of you may know that I had delusions of wanting to be a neurosurgeon, and I wanted to be a neurosurgeon from the age of about 13 to becoming a neurosurgery unaccredited trainee, and did 1 year as a registrar, did my surgical training, did 1 year as a neurosurgery registrar, and within the first month or two of starting that job, I realized that I had made a terrible, terrible mistake. And I had my desktop screensaver was a countdown clock, and I remember there was more than 300 days to go as the year counted down. And I realized that the thing that I actually enjoyed was the radiology. And so that's how I ended up in radiology. But back then, which wasn't that long ago, the prognosis of having a glioblastoma was dismal. It's still dismal, but STUP protocol, which is concurrent temozolomide and radiotherapy more than doubled the life expectancy of patients with GBM. And that is standard first-line therapy. So maximal safe surgical resection. How much is maximal is something that is evolving, and I think there's a move towards more aggressive resection, particularly of non-enhancing tumor, followed by concurrent temozolomide and radiotherapy. And that's great, but it's made our job harder. So before this, the two sequences that you would use to assess tumor progression were just flare and post-contrast. And it's still, you know, the very important sequences that you want to look at, and look at multiple priors to get a sense of what's going on. But the presence of STUP has meant that pseudo-progression is more of an issue. And what do we mean by pseudo-progression? Well, pseudo meaning not, or mimics progression. So it looks like the tumor's getting bigger, but it's actually not. And in fact, not only is pseudo-progression not a bad thing, but generally indicates a vigorous response to medical management. So it's a good thing. So if you've got pseudo-progression, the last thing you really want to do is change therapy because it's working. Now, clinically, there's a really good clue, and that is that patients with pseudo-progression usually are much better than their scan. So you'll call up, if you get it wrong and you call it progression, and you give the oncologist or the surgeon a call and you say, oh, you know, looking terrible. They'll say, oh, that's bizarre. I saw them this morning. If you're late in reporting, I saw them this morning in outpatient clinic and they were fine. So, you know, they're not on any steroids. They're doing well. So that's a really big clue. Assuming you don't have that, and you don't often have that sort of clinical information, what are we going to base it on? Well, you're going to look at flare and T2 for edema. And again, you're going to try and distinguish between tumor and just vasogenic edema. Because the reason pseudoprogression occurs is that you get florid breakdown of the blood-brain barrier with lots of fluid overcoming the brain's ability to clear it. So you get accumulations of vasogenic edema. And the blood-brain barrier is also what keeps gadolinium out, so that will also leak in and you get enhancement. So if we look at this patient, well, there's a lot of vasogenic edema. Notice how now it's much more evenly spread around the resection cavity. And if we have a look at the post-contrast, that looks pretty nasty, right? There's some maybe solidish components, but note that most of it is fairly thin and rim-like enhancement of the cavity. The one area that's concerning is down here, where it is more nodular. We'll come back to that. And notice that tongue of tumor. Remember how there was just vasogenic edema heading down there? Notice that there's now some enhancement going down there. That's concerning down here. So if we have a look at T2, again, see that beautiful vasogenic pattern. Lots of high T2 signal washing up against the borders of the cortex, and we're seeing really high signals throughout this. Here we're fading into normal brain. As we come inferiorly, note again here, it looks a bit darker than before. Not much to see at the bottom. We know where to look, so we're not going to look at DWI, we're just going to go straight to ADC. Up here it all looks fine. We've got cortex that's very cellular. You know, lots of dendrites holding those cells together, makes them very difficult to spread apart with extracellular fluid. And where we've got that enhancement, we've got a thin rim of low signal, but nothing really nodular. Up here where we thought there was nodular contrast enhancement, in fact, we see nothing very much at all. But again, look at this area. Look at all of this area here. It looks like edema, but there's lower values suggesting higher cellularity. And this lower component, that's really worrying. If we move to perfusion, we see that a lot of this peripheral ring enhancement doesn't have very high values. Remember that what you're trying to compare to primarily is normal contralateral brain, not the surrounding brain, because here we have very depressed CBV, because all that brain is swollen apart by water, which is not perfused. But when we come inferiorly, we see that solid, more nodular component, especially this bit that's creeping towards the lateral ventricle, has increased CBV, higher than the contralateral side. So this is concerning for a mixed picture, and I think this is difficult to report. And we'll move on to the next question because I want to talk about this a little bit more broadly. This is a common problem, and I think anyone who tells you that distinguishing between pseudoprogression and progression, let alone between progression and pseudoresponse or response and pseudoresponse, is making it sound easier than it is. The reality is that you almost always have a combination of effects, because temozolomide and radiotherapy are highly physiologically active treatments. So they do have an effect even in patients who have progression. And in patients who have wonderful response to Stupp protocol, they all end up dying anyway, or almost all of them. So they all have a tumor in there. It's either biding its time, might be microscopic, or it'll come back. But it's not like there is no tumor. And you often have tumor growth in some parts and treatment effects elsewhere. So how you report these, I think, is difficult, and you need to have a conversation with your oncologist and your surgeon so that they understand what you mean. I tend to reserve the term pseudoprogression when I can't find any evidence of progression, and therefore I'm saying everything you see here is treatment effect, pseudoprogression, but it looks like progression. And I'll call progression when I think there is definite growing viable tumor, even if there are components of treatment effect. In this case, well, it's a bit hard because there's a large amount of treatment effect up top, lots of vasogenic edema, no elevation of CBV around thin surgical cavity enhancement only. But inferiorly, there's that nodule of tumor that's growing towards the ventricle. So this is mixed. There's progression inferiorly with large component of treatment effect superiorly. And hopefully what would happen here, and what did happen in this patient, is that they get a short-term follow-up scan and get a decision is made on change of therapy. Response versus pseudo-response is a completely different kettle of fish, but we'll get to that because this patient is complicated. So they got a short-term follow-up scan, which I'm not showing here. Things got a bit worse, particularly that inferior nodule got lumpier and progressed further towards the ventricles. And so they were moved on to now the most common second-line therapy, which is Avastin, bevacizumab, I think. Which is an EGFR, endothelial growth factor receptor inhibitor. The mechanism of action is that it stops angioneogenesis and actually sort of stops the normal function of vessels to a degree and starves tumor from the nutrients and oxygen that it needs to grow, which is great in theory. The problem, both for us and for patients, particularly for us, is that it is a tremendous restorative factor on the blood-brain barrier. It's like steroid, but like version 24 of steroid. So it creates an intact blood-brain barrier and therefore stops edema and stops enhancement. And so if you're used to focusing on edema and enhancement, particularly enhancement, as the determinant or the determining feature that you're going to base your assessment on, you're going to make mistakes in calling response when in fact you don't have response, the tumor's happy, just not enhancing and not edematous anymore. So let's try and work out which of these two this patient went on to get. So if we go to the post-contrast scan, remember that big nodule Well, that's enhancing much less than it was before. Note, however, that the size of it hasn't changed a great deal. There's much less mass effect in this region, and that's due to the fact that the edema has all but vanished, which is great. But this is the powerful anti-edema feature of Avastin. If we look at ADC, because we know where to look, you'll see that down here we still have lots of low values extending. Look at that nodule right there. When you take a tumor and you kill it with chemotherapy or radiotherapy or whatever, you're lysing the cells, you're increasing extracellular fluid, and the ADC values go up. This is a viable tumor that's living quite happily, just probably not able to grow quite as well, but it hasn't died. More importantly, when we go up to the top here, we'll see that best on T2. See how this gyrus is now grossly expanded superiorly. See that really well on this Spinecco flare. And notice the difference in signal intensity between what this looks like now and the edema that we saw before. And on T2, notice how parts of the cortex are involved. Some of it seems spared, but look at that area there. That cortex is infiltrated and abnormal. But when you go to post-contrast scanning, come to the top, it's sort of underwhelming. There's less enhancement here than there was around the surrounding, the resection cavity before. So if you're just focusing your attention on contrast enhancement, you would call this response. But in fact, not only is this not response, but pseudo response down here, you've actually got progression. And so here we've got a patient who started off with a GBM, went on to get treatment effect or pseudo progression with some tumor progression. That grew, he was changed to Avastin and got pseudo response, but continued progression at the same time. So all these effects can happen concurrently. Let's have a look at some of your questions. Well, we have to go back a bit. Right, so MR spectroscopy, I didn't touch on that too much. Yes, within the surrounding edema, looking for elevation of choline is helpful in distinguishing tumor infiltration. And remember that choline is a marker of cell membrane turnover. So in tumors that have infiltrating cells, the choline will be up in areas that might look just like non-enhancing tumor. It's particularly useful if you've got a metastasis with lots of vasogenic edema around it and you're not sure whether this is infiltrating tumor or not. Because in a metastasis, there's no tumor cells in the surrounding wet white matter. So you'll have a normal trace. Whereas if it's a glioma, it may have detectable elevation of choline. Well, that's a great topic. So how much spectro? So we use spectro all the time on all our glioma follow-ups. How useful it is in the setting of pseudo-progression versus pseudo-response and true progression and true response, it is useful. It's yet another piece of evidence pointing you towards one direction or other. It's not a magic bullet by any means. And I would put more emphasis on perfusion and ADC, especially ADC changes over time, than I would on spectroscopy. The other problem with spectroscopy is that to get voxels in exactly the same place containing the same tissue is not that easy. And so it is hard to accurately compare one study from another. From a diagnostic point of view, I think it is helpful. So, case 4. I think it's time for a drink. A 25-year-old female with headaches. Well, problem solved. We can see why they have headaches. She's only 25. has these massive ventricles. By the time you get ventricles of this size, you know, one, they've had hydrocephalus for some time. You don't know how long, but it's not today, because if a 25-year-old was perfectly normal yesterday and then suddenly obstructed their ventricles, say from colloid cyst, then they would be obtunded way before their ventricles got this big. But you also know that there is ongoing acute obstruction here because you have extensive transependymal edema. We can follow it down. We've got nice patent foramina of Monroe, enlarged third ventricle pushing inferiorly into the supraoptic recess. The temporal horns are massive. We can follow the aqueduct down into the fourth ventricle that appears distorted, and we can see that there's unhappiness here in the right cerebellar hemisphere. Did I say right? Right, left. Radiology, this side. And even on non-contrast, we can see different density components. Now, this component, I know that this is abnormal because I've seen the contrast studies and I've seen the MR. But beware of calling an abnormal dense vermis, because it's not uncommon for it, especially if it's pushed a little bit, to appear somewhat hyperdense. But this component is definitely abnormal. And this low attenuating component is definitely abnormal. And the more you look, the more you think maybe all of this hemisphere is abnormal. When you think about things that are hyperdense on CT, what do you have? You've got meningioma, and that's because either they're very fibrous and highly cellular in a non-aggressive kind of way, just in a swirly, compact kind of way, or they have psammoma bodies, which can increase the density because they're microscopic flecks of calcium spread throughout the tumor. Hemorrhage can be hyperdense, but this doesn't really look like hemorrhage. And highly cellular tumors, just like they depress ADC values, can also elevate CT values. And so we're looking at small round blue cell tumors, lymphoma, medulloblastoma, pineoblastoma, etc. We're not seeing very much else, so let's move on to a real test. And here we've got an MR, and we can confirm that there is this vermian component, this cystic component with what you might be tempted to call a mural nodule. That's probably not the wrong thing to call it. If you say that, you might then be tempted to go down a direction of differential that you don't want to. And then this third, more peripheral component. If you're only given this, it's hard on these purely axial images to be certain of whether it's intra or extraaxial. But given that the other ones are clearly intraaxial, they're probably all intraaxial. If we go to post-contrast, we can see that the enhancement is very heterogeneous and different from component to component. We've got a vermian component, we've got this component next to the cyst and this more peripheral area. This one enhances the most. We can have some beautiful anatomy here on thin T2, which shows that wonderful inferior bowing of the third ventricle into the supraoptic recess, the infundibular recess, the floor of third. Notice how the third ventricle, the beak of the bloody hummingbird, is depressed. And this is a very good sign that there is a pressure difference between here and here. So this is acute third ventricular hypertension. No one uses that term, but the pressure inside the third ventricle has to be higher than the pressure in the interpeduncular cistern, or otherwise that floor of the third ventricle wouldn't be displaced. And we have widening and funneling of the aqueduct, and we've got widening of the pineal recess, and down into the fourth, and then we've got obstruction at foramen magnum. Now we know where to look because we've seen it on contrast and on T2, so we're going to go straight to ADC. Remembering that normal white matter is about 750 and means that we're looking at a cellular tumor if it's that low. And when we get down to this, well, that's at least that low. It's probably a little bit lower. So this is a highly cellular tumor. You can measure this just like you measure Hounsfield values on CT. Put a ROI on it, get used to the values. they're all very predictable, just like Hounsfield values. And then you can start talking in terms of values rather than in dichotomous there is or isn't diffusion restriction. This component's quite low, similar to CSF, to white matter. Here there are components that are lower. So what's our differential here when we start to think about a youngish patient with a lateral and Vermean cerebellar lesion? Well, the moment you say cyst with a mural nodule, you're going to be thinking of two lesions, and that is pilocytic astrocytoma that do occur in this age group. In this age group, they're more commonly supratentorial, but that's certainly a possibility. And hemangioblastoma, and they do occur in this age group. This would be more common in the setting of von Hippel-Lindau, where there could be multiple, so we do have multiple ones here. You'd want to quickly have a look at the retinas to see if there's any retinal angiomas that would make the diagnosis. But the thing that stands against this being hemangioblastomas is that these are quite large lesions, but we're not seeing any flow voids from abnormal vessels. And by the time you get to this size, usually hemangioblastomas will have really prominent flow voids seen best on T2. More importantly, neither pilocytic nor hemangioblastomas would be expected to have this degree of ADC suppression or reduction. So what highly cellular tumours of the posterior fossa do we know? Well, medulloblastoma. Now there's a bunch of medulloblastoma, and this is one of those tumours that's worth knowing the molecular classification, because the WHO now includes molecular classification into it, and it's something that we as radiologists can predict to a degree. So there are 4 groups, and they're quite distinct. We have WNT, which stands for wingless, because I think the same gene in Drosophila fly, when you delete it, means the fly doesn't have wings. I think that's why it's called that. We have sonic hedgehog, which has got nothing to do with hedgehogs, but is just was named by the researcher after the comic book that also inspired the computer game. And then we have unimaginatively named Group 3 and Group 4. When we think of our typical medulloblastoma in children that occurs in the vermis, we're really thinking primarily of 3 and 4. They have bad prognosis. Depends on the study that you read, how you rank these 3, but usually Group 3, to a lesser degree 4, have terrible prognosis. Wingless is a bit of an odd one. You don't see this very much. It's particularly in infants, and usually occurs in the middle cerebellar peduncles, and has actually a pretty good prognosis. Much better than the other ones, and cure is not infrequent. Sonic hedgehog falls a little bit in between, and it can be seen in kids, can be seen in the midline, but in young adults, it's seen in the lateral part of the cerebellar hemisphere. It is typically heterogeneous in appearance, with cystic areas, solid areas, but it will still have low ADC values because it can't help but be a small round blue cell tumour. In addition to the molecular classification, you will also get a histological classification, like classic and anaplastic and desmoplastic and nodular. And the nodular desmoplastic type is almost always sonic hedgehog and is almost always in the lateral hemisphere. So in this case, you can actually predict the molecular subtype with a fair degree of certainty based on the MRI. And they went on to have a histology and desmoplastic nodular and sonic hedgehog. So that's great. Now, it makes you look good if you're using the right words and you can predict this. No one's not going to do the test based on a radiology report, but it does, when it all makes sense and it all fits in, everyone feels a bit more calm. Last case, case 5, 50-year-old man with a seizure. So immediately we can see an abnormality involving here the left insular cortex. It's quite irregular. There's some areas of low T2 signal that maybe it's a flow void. Very ill-defined margins. Mass effect is minor. If we go on to contrast, because we don't want to spend our entire life looking at this, we're not actually issuing a report. We don't see any contrast enhancement except maybe a little bit around these low T2 signal regions. Some of these are vessels. Right? You can see enlarged vessels coursing towards this lesion. And if we go to ADC, we don't need to look at the DWI because we know where to look. See mostly facilitated diffusion, so it's brighter than normal white matter. And if you measured this, you might get 1400, say. Except for these areas that are very low. We'll have a look. Do we have the B0s? No, we don't have B0. B0 DWI component. It's an EPI, so a T2 star weighted sequence. So it can be useful just to look for blooming. But we do have susceptibility weighted imaging, which brings us to a question, which is susceptibility sequences. How do we use them? Well, let's have a look. The one you're most familiar with is just going to be your normal SWI, susceptibility weighted map. And this is just a very good T2 star map that has superseded gradient echo or merge or EPI. And anything that upsets a T2 star field will cause signal loss on susceptibility weighted imaging. You will have it usually presented both as a normal sequence, say 3mm thick contiguous slices, and as a MIP. It's not really a MIP. It should be, it's a min. It's fading too fast. MINIP, because it's minimum intensity projection. You're taking a slab of tissue and taking the lowest value, so the blackest area, projecting it through. And this is typically, say, 28mm thick, and they'll be overlapping. And all that this does is make it easier to get the idea of the venous anatomy. And you get these beautiful venous maps with MINIPs, where you have, for example, here your thalmostriate vein joining the septal vein, forming the internal cerebral veins, draining posteriorly here into vein of Galen and straight sinus. And it makes it a little bit easier to see whether a dot is a microhemorrhage rather than just a vessel end on, because most of the vessels are elongated through the slab. And so here we have these areas of susceptibility induced signal loss, but it doesn't really tell us on these maps what it's made of. Now, there are two ways that you can affect your magnetic field, and that's using paramagnetic and diamagnetic compounds. Now, diamagnetic, and that's to do with whether they pull the field towards it or spread it out. So they move, they affect the magnetic field in opposite directions. And when you look at the direction of phase shift that they have, it'll be in opposite directions. So diamagnetic, like bone and calcium, will go in one direction, and paramagnetic, like deoxyhemoglobin and hemosiderin, will go in the other one. And the maps that you want to look at are these susceptibility phase maps. Now, there's a little bit of a trick to this, because you'll notice that the bits that don't show phase shift, like normal brain, that's your mid-value grey, right? So 128 out of 256 shades. And then how far you have shifted phase will be mapped either towards the black direction or the white direction. But the direction that that will occur in will be dependent on the direction of your main magnetic field. And vendors have not agreed on a standard. So some vendors have the main magnetic field going from the head to the feet, and some vendors have it the other way around. So there's no absolute way of just looking at it. What you need to do is you need to look at some internal control to give you an idea of what paramagnetic, so deoxyhemoglobin and hemosiderin, does versus diamagnetic, calcium and dystrophic calcifications. Fortunately, in adults, you'll have examples of both of these. So if you look at the internal cerebral veins, they're filled with deoxyhemoglobin, so that tells you that that's the paramagnetic direction. And if you look at your pineal calcification or choroid plexus calcification, you can see that calcium diamagnetic is going to be black. So if we look at most of this, it's mostly black. But I hear you say, well, what about all these white bits? Well, that's the trick. I remember years ago when I was still a general radiologist, when you do ultrasound and you're trying to examine a flowing vessel with Doppler and you set the range too low so that the waveform exceeds the upper margin of your range, then you'll get aliasing. And this is the same thing that's happening here. When you have a large clump of hemosiderin or calcium or whatever, if it induces enough phase shift so that you wrap around, you end up appearing to have gone the other way around. And so you'll get aliasing and you'll get the sharp transition between black and white. It's not always possible to distinguish whether it's a splodge that should be white with black areas or a splodge that should be black with white areas. But generally you will see that a dominant pattern emerges. White, mostly black, sorry, black up here, black with a center of white, black, black mostly. So this all looks very similar to what you know are calcium. And so this would fit with calcification. And in this setting, you've got a diffuse tumor with some prominent maybe vessels, but no solid contrast enhancing component with calcification. And that's very likely to represent an oligodendroglioma. When we look at the perfusion, you can see those are prominent vessels going down, but there's no real solid elevated areas of CBV. One thing just to be wary of, if you've got oligodendroglioma histology, which can have this chicken wire or staghorn vascularity, that can elevate your cerebral blood volume without it meaning that it's a high grade. So just to be aware of that. If you think it's an oligodendroglioma and you see elevated CBV, it doesn't necessarily mean that you're looking at an anaplastic oligodendroglioma. It just might have prominent oligodendroglioma vascularity. So we have histology, and here we go. And so just the one thing that I wanted to mention was, because this is kind of the key to understanding oligodendrogliomas, and that is that to be an oligodendroglioma, you have to have an IDH mutation, and you have to have 1p19q codeletion. You need to have both. One thing that you need to be aware of is that IDH, there are two types. There's IDH1, which is in the cytoplasm of cells, and IDH2, which is mitochondrial. They're the same Krebs cycle enzyme. And they both can get mutated, and they both cause diffuse low-grade gliomas or lower-grade gliomas. About, I never remember these exact figures, say 80, probably more % of all IDH mutations are in IDH1. And of those, another, say, 80% are this one base pair mutation, which is a swap from arginine in position 132 to histidine. And you can test that with immunohistochemistry, which is great because it's a cheap, easy slide that can be done at the same time as normal histological assessment with all sorts of other immuno. It'll just be part of the immuno panel. And it's great if it's positive. So if you get staining for this mutation, you know they have a mutation, and you can go on and do 1p19q codeletion and you're done. The difficulty comes if the immunohistochemistry is negative, because then you're looking at, depending on the age group, a significant likelihood of there being a non-R132H IDH mutation. So you need to have sequencing. And that's what they've done here. They've done it anyway. Even though this was already positive, they've gone on and done the sequencing and confirmed that this was there. And we've got the idea, the 1p19q codeletion. So we've now established a WHO diagnosis of oligodendroglioma. And that's important on a number of features. One, because now you know what it is. Two, no matter what it does, this can never grow up to be anything worse than an anaplastic oligodendroglioma. So it can't go on to become a glioblastoma, even if it ends up with necrosis. And that's because the prognosis of an oligodendroglioma, molecularly speaking, with necrosis is still much better than a glioblastoma. So that is it, folks. I don't know why. Wrong buttons. Let's have a quick look at some of these questions. And how long does it take to learn all this information? Who is not a doctor or medical person? Very interested. It takes a long time, and it all depends on how much you sleep, I guess, and how many other hobbies you have. And most importantly, you never, ever, ever stop learning. So here a question from Jugal James. Does 1p19q codeletion cause flare suppression? No, the opposite. So in fact, that's something that's come out relatively recently. And that is, if you have a tumor that looks like a diffuse glioma and areas of it flare suppress, meaning just like we saw in that area of really prominent vasogenic edema, areas that are super bright on T2 that lose some of their signal on flare, not a cyst, just part of the non-enhancing solid component. That is highly predictive of a diffuse astrocytoma. It's what we used to call a protoplasmic astrocytoma, but you're not allowed to use that word anymore for some reason. But it means it's not going to be an oligo. Thank you, everyone. I hope that's been of some use. I know we've gone a little bit over time. Again, I wanted to thank all of you who have been here today, all of you who have attended the conference, all of you who have commented on Twitter, submitted a case, edited. I want to thank all the editors and all the volunteers who have really helped bring this conference together. I wanted to thank Everlight Radiology, who basically forced us to allow them to sponsor us. They've been a long-time sponsor of us, and it's been great to have them involved. They've helped us generate English language captions for all our talks, and that's really useful for many of our listeners. So thanks again, everyone. I hope you enjoy the rest of your day or evening or week and the rest of the conference, and I'll see you next time.